Start recording.
You're good, you're good. You don't have to hit anything. You're live.
Hello everybody, Dr. Facer here. Appreciate you guys tuning in today. It should be a great day to do a case. Today's case is kind of interesting. It's a little different than I've done in the past because today is going to be more about patient management. I mean, it's a great case, don't get me wrong, but we all have those days where patients have issues. Now, this patient's issue, and as we watch the video, I want you to pay attention to it. He had this kind of a Tourette's tic. And so if you watch my face, what he would do is and it's not exaggerating, he would just crank to the side like out of nowhere, really sudden and very forceful. Now, the reason why I bring that up is it didn't really appreciate that in the consult. You know, he hid that pretty well. But when I got started, I'm like, oh my gosh, this guy's, I put something in his tooth. It almost felt like he felt pain. You know how patients, when they feel pain, they pull away? Well, if it was that kind of sudden withdrawal, like a cold test withdrawal, but it was out of nowhere for no reason. He's listening to headphones and happy as a clam. And so that was kind of what was unique about this case. Now, this Xray, let's see here, is what it is. So it is tooth number 30. And, you know, the history is filling done some years ago. It was unknown if this was a pulp cap or a pulp exposure up here in that mesiobuccal pulp horn. And really strong attrition, like he had these wear facets that were not carious, but definitely indented through the enamel. And it was a symptomatic periodontitis. He had tender to biting. And if you notice on this 2D X-ray, there is a lot of pulp stone anatomy going on. And if you look at the way that these periodontal ligaments, now this is 2D, you know when you look at this may at first glance like, oh yeah, it's super easy. But the problem is that lateral anatomy or that isthmus anatomy. Certainly we can see that on the mesio root, but what about the distal? I mean, it looks kind of straightforward, right? So stay tuned and check that out along the video. Let's go back here now. So that's the case I'm going to present today. So patient management issues is the highlight, and we're going to go through how and why GentleWave was useful in this case, which is why I wanted to show you all about it. So, all right, let's go here and give this a go. We'll give this a start. And anybody who's watching live, I have Vicky over here ready to tell me what's going on. So you talk to me, folks out there in the endo world. Okay, so root canal number 30, like I described, pulp necrosis. Now, there's always this deal with patients sometimes where the histological or the clinical findings are different than the testing that we did. So for instance, this tooth did not feel cold, or we diagnosed it as necrotic, but when I got in there, it was more of that ischemic tissue. It was that there was still some organic matter still in there, so it wasn't completely necrosis. It was the mostly dead scenario. For any of you that watched Princess Bride, mostly dead. So traditional access, you'll see that going on here. By the way, before we get going too far into this, the bottom left-hand corner of that screen there's a red box, and that's actual clinical time. So everything that you see on that box is time-stamped. So the timing of what's transpiring here is actually accurate. So we're doing an access here, and I used a couple little burrs. The first burr actually isn't a burr I use that often. It was just sort of a 357 crosscut carbide. This one that I'm using right now is just a diamond access, endo access burr with a little ball on the end. And that's kind of my go-to burr. It just, for whatever reason, started with a 357. Did a little access, and then I'm bumping into these pulp stones. And pulp stones are always funny. Sometimes they look like pulpal floors, but they're not. They're pulpal stones. I'm a big believer in removing those stones off the pulpal floor, so I will do that. And what I do may be a little bit different is I'm going to see if I can bite around the stone with this Universal SX from Dentsply. I like it because it's super stiff. I joke, and people have heard me say this before, I just call it a rotary explorer. I'm only really picking and seeing where it goes, and I'm just trying to dislodge any of those stones. And you know, I know there's stones in that isthmus, that lateral anatomy in the buccolingual space. And then this is an Endo Z burr, and I really like that. And part of the reason why I'm using the Endo Z here is I'm not really that concerned like I used to be in my career of removing all pulp horns and all the pulpal roof. But I'm using it because as I'm into that, I'm noticing that feeling where I talked about maybe that was a pulp cap. And I was sort of like leaning up against into that composite because I wanted to know if it was a pulp cap, and I wanted to know if I'm going to use a GentleWave on this case, if it's going to wash out. And what I was doing with that burr was just sort of, and in the perspective of the microscope, was I'm visually looking to see if that's carious or if it's some sort of pulp cap material or something going on in there. And so I'm talking to Lindsay. Down in the bottom left-hand corner is just kind of a bird's eye view of what's going on, and you'll see this is real life stuff, so there might be other assistants walking in and out of the room and stuff like that. And so if I'm getting confident that it's not decay, and I'm very suspicious of it, that's something I got to think about in the GentleWave procedure, because I need to maintain that sort of closed seal in order for this technology to work. And we'll go through that technology by the way. Now that I've kind of filed into this thing, I'm just hand irrigating sodium hypochlorite. I use basic syringe and a 30 gauge maxi probe tip, and I label them all. So if you kind of paid attention, I labeled that to say sodium hypochlorite. Now, remember I told you about the tick? This little boom comes over. It's like Britney Spears in that Pepsi commercial, and she kind of did that wink. Well, if you notice on that screen, it isn't that I'm like fidget. He is like moving off out of field of view. So pay attention to that along this video. I'm moving pretty fast on this video. What I did there is I took alcohol and I went around it to dry everything up, and I went right to GentleWave. I actually knew the ends were so open. I used see, there you go, here's his movements. I used the files significantly smaller in that. I was just creating a pathway for the fluid dynamics, and then coated everything around with that sound seal. And honestly, what's in my mind right now is platform, platform, platform. I want platform security is what I want. Make that sucker as secure as possible because of his movements. I mean, I know I got to maintain a seal, but I don't want to dislodge if he's going to pull away from me. And you know, the trade-off of that is what would happen if I was trying to thread the needle with a file and he pulls away? I mean, that's where I'm going to get into trouble with file separation with those kind of extreme movements. So this was definitely a procedure of choice here. And so I built up all the way around that tooth with excess, curing it, and that little jig that you see that I'm holding with hemostats, it's just a platform build, it's just a matrix. And it's just going to make a depression in that sound seal for the procedural instrument to sort of marry it together and create a connection. I also put a sponge in it, and I always joke and I call it the breadcrumb. And I just pass a file in to pull the breadcrumb out. So breadcrumb meaning I know my way home, right? And now, because I'm thinking in terms of movement, I'm actually re-accessing this a little bit different, and I'll explain why. I'm just taking a round burr, nothing special, but I'm checking that interface from where the tooth and the sound seal are married, and that butt joint, that margin, that connection, if you will. I want to make sure there's no voids and nothing is going to dislodge or happen in there. So I'm just taking a round burr and I'm going around like I'm a router, and I'm looking at that interface. And then I'm hand irrigating here because, after all, I create sawdust every time I use a mechanical instrument, rotary or file, like a burr or a file. So now I'm just flushing out the debris, and I'm going to really inspect that margin. And if you look at that kind of distal lingual line angle or mesial lingual line angle, there's a little bubble there. I'm going to go the extra mile right now. And that's the thing about Sound Seal, it's so forgiving. It's so easy to work with. So it's not like conditioning and bonding in that. I just fill it back up and then we'll light cure it again. And I'll just take an Explorer or, the tip of that Sound Seal. I just used it to smooth it away. And then I'm just going to cure it again because I don't want anything to dislodge with that kind of movement. 10 minutes into this case. So what have I done? I've accessed, picked out stones. I found the anatomy. You can appreciate the isthmuses, because we knew it on the mesial, but there's definitely one right there. Did you see it? On the distal as well. And now that that's built, I'm 10 minutes, 29 seconds in, and what I'm doing with these little colored depth gauges is I'm trying to scratch and feel the bottom of the floor. And the last one that I used, I went red, then I went blue. And if you notice, this is a green cap because the blue barely touched. I felt like it was probably just the undulations in the pulpal floor. I could feel like a bump somewhere. So then I just go one side smaller, which is the green. And that was the cap I selected, put the cap on, and then lo and behold, I'm just connecting it to this platform. All right, so what does corporate have to say about this? And what is this business of GentleWave? Like, what does it do? Well, it's about cleaning and disinfection, and they're reinventing the way that we do it. And it's a true reinvention. It's really amazing. And like they claim, it's like unsurpassed cleaning and shaping. Like, really? Yeah, really, it is. And you know that by as you start using it, you kind of get your belief system and you start reinforcing it based upon your own results. And that's kind of why I'm here today, because it's been a crazy, fantastic journey. So how does it work? Well, the secret is in the console itself, which is what this image is about. And it has this sort of patented way of degassing all the ingredients that we put in, meaning EDTA and hypochlorite and actually water. And it comes through the console and through this procedural instrument, and as it comes through that, it hits this sort of sound bar and this sound plate, and then that's where the mechanism of action takes place. And in that animation, what happened is it hits, and it creates a cavitation cloud from shear forces of this fluid dynamics, and then it's just sort of hovering over the top. The cavitation cloud is hovering over the top of all the orifices and the isthmuses of it. Now, it's a really fascinating story, but pay attention to this video as well, because you can see how much this guy is wiggling on me and how much I'm having to stop and start again. But the trade-off is that could be a file going on here, and I want to show you how this thing works. So anytime you disconnect from that interface, by the way, the console stops. And then you can adjust, make sure you're talk to the patient, tell them what you're doing, why he needs to hold still, or he or she needs to hold still, and check your platform, and then re-engage. And then the time clock will go through this sort of repriming, phase before the clock starts counting down, and then it just kind of picks up where you left off. That way it's maintaining the true protocol. Because this first part of hypochlorite, hypochlorite rinse, EDTA rinse, those are the ingredients. They're very much regimented, and they're always the same depending on what you pick. So, vital and necrotic are actually the same protocol, whereas retreatments are different in the console timetable. Now, if you look really close at what's going on in here, you're going to start to see a pink cloud in the window of that sealing cap that's touching the sound seal. And it looks like a pink cloud, and sometimes it will look pink, sometimes it will puff pink. And what that's doing is this mechanism, as the degas fluid comes down and creates the cavitation cloud, it's generating negative pressure. And it's also generating sound. As those bubbles expand and collapse, there's a sound wave that's created. And that's why they call it multisonic. And it has to do with kind of like white noise. It's just the spectrum of sound, and it echoes, or it goes through the fluid. Sound actually travels faster through fluid than it does air, by the way. And it goes down in a negative pressurized environment. And I'll joke and I'll say it's like it's given the tooth a hickey. So when it comes to apical periodontitis, you'll see kind of this sort of intrusion or extrusion, depending on your perspective, of what's going on in the supporting tissues. And in this case, it looks like bleeding, and that's what's happening into this. As I've been talking, 15 minutes, 31 seconds has gone by in the treatment. And now it's just, in this case, dealing with the patient and watching him move. Just move. He just moves. We hate that, don't we? We're control freaks, isn't it, on us? Look at that, all the way to his eyeballs. He blinded himself by looking in the microscope light from that tick. Okay, so get us back in focus and going again. Like I said, it doesn't chintz on change of the clock. Now, a couple points like I talked about. I made a pathway with that instrumentation. It was really quick. If you go back and watch the video, it was only, and it's that red clock is true to the time. It was only a few minutes. And like I said, the idea of establishing patency didn't happen on this case. I wasn't going to patency file, certainly because of I'm relying upon the GentleWave. And I love pointing that out for you guys to just think about that. And as you use the GentleWave, consider that talking point. But what I did do is part of the reason it was necrotic and I already had empty space to begin with. And I just wanted to make sure that fluid flow and that sound wave could get to the terminus. I know we can debate about terminuses, but I wanted to make sure it could get there. And so the job of the file now is to just create the pathway for the fluid, as opposed to planing the walls, establishing patency, because actually patency and that traditional concept is coming from the fluid dynamics. So I'm going to get patency as evidence of the apical negative hickey bleed that's going on. So patency is getting done. I just didn't mechanically do it. That's what I'm saying. All right. Still see the puff of pink clouds. I could just noticed it there. 17 minutes, 42 seconds into this case. And the other thing, if you go back on the video as I was sort of narrating this, go back and pay attention to that lateral anatomy, that isthmus anatomy, and what that looked like pre-GentleWave. So if you have to, just go back on the video, rewind it, watch it again, and pay attention, pause it, pay attention to that space. Because when we're done, I want you to pay attention to the space after the GentleWave and what it looks like. And it's a really cool thing to look at, because I didn't file that. That's my point. A lot of times during this time, if you look in the bottom left-hand part of the screen of what Lindsay's doing, I have her on guard on suctioning because of his movement. And you'll also see my left hand, since I'm right-hand dominant, my left hand just resting my thumb on top of it, because I'm actually holding under his chin. So when he moves, I'm moving with him like this. It's not force. I'm not holding him in place. I'm just going to follow him with two hands because I got sick of dislodging that. So just to make things a little bit interesting, let's look at the 3D, because I actually take 3Ds actually on every case. I'm a big believer in that. You can see my GentleWave is going, and I had a question in my mind about that anatomy, that lateral anatomy, and you can see it. You can appreciate the lateral anatomy, certainly in the view planes. Excuse me. And the mesial root is kind of funky, kind of figure 80 in cross section, and the distal root's really ovoid, but definitely there, and I consider that an isthmus. And you can see the abscesses as we go down. Those terminuses are in bone marrow space. Cortical plate covering the prominence, eminence of the root. Abscess formation there. And there's your cross-sectional anatomy of this tooth. Patient has a... There we go. All right. All right, so now that I'm done, we're going to take this off. Now, a couple talking points. I paid attention to that mesial wall. That composite stayed intact because what they did when they built that composite up, they actually didn't remove all the decay. It was an indirect pulp cap. In hindsight, 2020, right? Figured it out. It was an indirect pulp cap. And the reason why I know that is as you watch as I'm flushing this out of the system, I start paying attention to that mesial wall, and sure enough, the GentleWave actually removed that tertiary dentin and that sort of affected dentin with caries. So what was left behind from the filling was actually removed with the GentleWave. And I'm going to get a close-up on that. When I'm irrigating post-GentleWave, my preference, there's a lot of things you can do, but my preference is to use 3% hypertonic saline, and I just kind of introduce that to everybody, and it just works really well for me. I like it. It's not a chemical reaction. It's not chemical cautery going on at the apices. It's just sort of causing natural clotting, and by the way, blood clots float in saline, so the more saline, the easier it is to float a blood clot up. So I like that concept. But because I did not establish patency and I didn't do a true length other than measuring on a cone beam, I want you to see what those 30 cones look like on an Xray right then and there. So, but back to that wall, we're going to get up to it here. Pay attention, you'll see a trough tunnel right underneath that composite. And if that wasn't a very well set composite, it actually just would dislodge the composite, by the way. But because the composite was built on active dentin, it stayed intact because it had, you know, a true bonded surface that composite was built on. So I think that's a great technique for the dentist to do it that way. I like indirect pulp caps, and I like GentleWave removing that and leaving the composite intact as well. So I'm going to suction out with a little micro suction just to look down these canals once the bleeding stops. And you know what? The time it takes to take an Xray is usually the time it takes to get the bleeding to stop. I take that Xray with those cones. See, there it is right there. Those cones are in saline when I took that Xray. So I'm still flushing it out, but really look at that mesial wall and you'll see that little troughing that I'm trying to explain. It is a lot easier when you're behind the microscope to like pick up on these little details than it is through a video, but trust me, it's there. There it is. So it looks like a little shadow right there. See if I focus in right there. So that, I didn't drill that out. I leaned up against it. I saw the discolored dentin. It's gone and clean, as well as the bacteria and the pulpal contents. So I'm going to put paper points in the ML first. You can see how that's kind of this new ovoid shape. I didn't instrument that shape. Now I'm going into the mesial buccal. And then watch this distal. So you can still see at the very end I have this habit where I'll still rinse with hypochlorite, and I'm just trying to get the right size paper point with 30, 25, now I'm down to a 20, and I'm going to wick out the juice in there, and you're going to see that thing, how clean that is and how that isthmus completely opened up. Now, like I said, go back and look at the distal space and then look at it now as I dry it and wick out the fluids in there. How clean that is. It's just pristine. It's fantastic. Love it. So I've gone down to smaller cones. My master cone were a 30. Those are 20 paper points. And now I'm ready to obturate. Once I get it dry, I'm going to do these one at a time. Again, it's a habit, because when they go 2 to 1 like this in the mesial root, if I really obturate well and I pick up isthmus space, that lateral dimension, the Z plane, if you will, I know I'm going to push whatever small amounts of fluid from one canal into the other. So I always like to do things one at a time, and if anything's in there, I can wick it out of the other canal with another paper point or whatever I choose to do. So a lot of times you'll see sealer flow up into the other canal as well. If you inject in one canal, it follows up the other. And that was the case in this one as well. So now I'm injecting sealer into the mesial buccal canal, I'm going to place the master cone. I stuck with 30s. I liked the way they looked on the Xray. Mind you, I was using size 20 paper points. Modified continuous wave. I mean, these are smaller shapes, but this case is just naturally big. So I've got a really tiny heated element that I'm putting in there. I'm going to down pack. This is a buck plugger I'm using. Onto the distal. I'm 27 minutes in. So if you watch that sealer come in, you can see how it's just clean. That all those pulp stones, everything that was in that distal root's open. That ovoid shape. Two to one in that, and I crinkled the cone there. So time to get a new cone. It's kind of behaving on me now, holding still. Gonna do a little down pack. I don't push terribly hard in these things. I mean, in a case like this, really the instrument's sort of hitting the walls and not putting a lot of pressure because of the size. And then I'm just using a heated element. This is now I'm going to the mesiolingual. And then back to the mesiobuccal. Down pack. And then it's just a matter of cleaning up the floor. Now, the question is, what do you do against that composite? So I'm going to show you how I flow into that space. I don't want to leave that space open. As soon as I finish playing with the floor. Clean up. People talk about clean up. Lots of different ways to clean up. I actually will use a burr to kind of polish the floor. I always feel like if I wasn't doing a permanent filling, I'm judged by the way that entry point looks. So I'm a fan of really making that nice for the general dentist. That's what I get judged by when they look at a tooth, after all. And then I'll clean up the sealer with just a bendy brush. It's yellow, and I use isopropyl alcohol. I use high proof, it's 90 proof, and to me that matters. And what I used here is, I don't know if you guys have ever done this, but this is just a parapost drill. I really like them because I'm not countersinking it, I'm not going in the canal with it, but I like actually using that on top of gutta percha. It just really pulls the gutta percha up. It was intended, the burr was designed to remove gutta percha, like in a post space scenario. Works really well because it is end cutting, and it doesn't really gouge your walls out. If you are accessing with a high-speed burr, you can just gouge it out. So just a trick, dental, just a little endo hack, I guess. And then I'm just going to clean up the sealer, the remnant sealer. I'll just clean it up off the floor. 31 minutes. So the instrument that I'm using now, like I said, is it's a perf paddle. And all I'm doing, since this is a temporary, I'm actually going to pack that with my cavit. This is actually, what's this called, Vicky? Coltine. It's Colposol. It's Colposol from Coltine Dental. And I'm just packing that in there, and then I'll put the breadcrumb in for the dentist now. So I just closed that wall up, made notations of it, and then I'm just going to close this up. The idea is I don't want to leave any voids in there, even for the dentist. I'd rather have, if he were to leave something behind, I'd rather it be this material than empty space or something that looks like an air bubble for his fill. And there is the obturation. So let's talk about this for a second. So what do we see here? Well, we see kind of a lot. Minimal instrumentation. So this is not a transportation scenario. I didn't use a file to transport, and it was already pretty large. But we can see what the file anatomy would do. You can see how open and where the apical periodontitis and the root terminus is, what was going on at that interface. And you can see this lateral accessory canal, this lateral canal coming off somewhere in that isthmus space of that distal root. And likely corresponding apical, some sort of rarefaction represented on this X-ray, and likely apical periodontitis going on there. We also see a lot of interesting shapes here. The kind of the ball and the squiggly line out here, extrusion of some sealer from that down pack. Remember, I was giving this tooth a hickey. So yeah, patency was done, but I had a true stop with a 30 cone. Accessory canal in 1 or 2 right here. Little canals where this was, the fin was opened up between, and that was really right underneath the orifice, which is also an interesting comment. And then communication to the periodontal ligament through here, and likely some sort of apical periodontitis going on there. So it made sense why his tooth hurt like a son of a gun to bite on. You can see where I packed this wall underneath that filling. The filling's intact here. And then here's my access. And these little points were those wear facets. If you go back in the video, you'll see the wear facets that were there. That's it. Job is done. Job is complete. So comments, feel free to comment at any time. Feel free to comment at any time. It can be after this live talking. You can just leave comments. We'll read them. I'll respond through the YouTube interface if that's useful for you. You can call me at any time. So thank you for watching a Dental Learning Live event and the GentleWave. Like again, in summary, the reason why I wanted to show this is it had some fun anatomy. It kind of had some of the talking points as to what makes GentleWave really powerful and really useful. Those fluid dynamics, when employed properly, are really advantageous for us as endodontists. Getting into that three-dimensional space that is just quite ominous, to be honest with you. You can see how the procedural instrument is viewed during the case. So you can see the hickey or the bleeding that was coming out, which I actually really enjoy seeing that. I know that is sort of patency principles are being achieved. I really like that. I really believe we're filling that at easier. I know we talk about how sometimes you can just force anything through. You can force sealer through something, but it doesn't mean it's clean. In this, for instance, I actually truly believe it's clean. People talk about how long it takes. Well, that's why I kept highlighting the red box in the bottom left-hand corner. That's how long it takes. And man, it's a fantastic journey. So hopefully you guys, if you have any questions, just reach out to me. Look, notify down below so you can be, can see when the next one comes out. I really am trying to do this true to form. These things just come out. They're not scripted. I'm not scripted now. The cases aren't scripted. They just come up. If it's interesting, we'll talk about it and try to show you guys interesting cases. So it's just not vanilla every time. So that's it. Thank you all and have a great day.